Dr. Sumedha, VATS. Yeah, please start.
And meanwhile, the next person should be ready. Dr.
Dr.
Vipul Arora on this side.
Good morning, everyone. Today I'll be talking about how we approached a case of granulomatous uveitis. We had a 47-year-old male who presented to us with sudden onset diminution of vision, floaters, redness and photophobia in the left eye of 7 days history. On examination, the right eye was thiacical. He had lost it to trauma 20 years back. The vision was PL negative. In the left eye, the vision was 618, a pressure of 48 millimeters of mercury. The anterior segment evaluation revealed granulomatous KPs, a flare and a cell of grade 1+. On the fundus examination, the media was grade 1, there was vitritis, a macular scar was seen, and a patch of retinitis in the infero-nasal quadrant was seen. So the point I want to make here is we got a patient with a history of trauma to the other eye and granulomatous uveitis in the seeing eye. We thought of sympathetic ophthalmia. The other possibilities that could be there were tuberculosis and sarcoidosis. However, I want to emphasize that a high index of suspicion for acute retinal necrosis in a case of granulomatous uveitis with raised IOP should be kept, and a thorough peripheral fundus examination is always worthwhile. Thank you.
What treatment was done?
The patient was started on IV antiviral, sir, acyclovir, 10 mg per kg body weight, 3 times a day for 14 days, and thereafter put on oral antivirals, sir.
And how the glaucoma was managed?
The glaucoma was, he was started initially on tablet Diamox 3 times a day, 250 mg, along with the topical anti-glaucoma, that is Simbrinza, the brimonidine plus brinzolamide and timolol.
So during the treatment, how was his IOP was maintained?
So
It was
on starting the anti-glaucoma, sir, it was managed by the same evening the IOP was under control, sir.
So because I really don't know, because you are not mentioned over here, if patient is one-eyed and upon the maximum medication, if the IOP is not controlled, I think we should not hesitate and go and do definitive procedure, what is required to bring down the pressure. Because already there is so much of a compromised eye, so we need to bring the pressure down immediately. And most of the time, initially, if the pressure is high, local medications don't work so well. So you give the mannitol or bring the pressure down, or do the paracentesis on the slit lamp and bring the pressure down, and then the medication starts working better.
So the patient responded instantly in an hour to the or two to the medication. So then we didn't think of mannitol then.
Okay, thank you. Thank you.